Uh, Good morning, everybody. At the best of times, it's difficult to follow a cataract talk by a retina talk, and following Dr. Suhas is extraordinarily painful. So, this talk is not about pure images. This talk is about a story in which AMD, a disease, has been revealed by OCT. Previously, you had these great doctors like Dr. Donald Gass, who used to look at the retina with 78Ds, and they used to derive where drusen came from, where different pathologies used to happen. And then the game changer was the OCT, where you could actually see, and it described these findings in a pathogenic manner. But nowadays, it's gone a step further, and in the US, there's a project called the Macula Project, where cadaveric eyes are examined to confirm these OCT findings once a patient dies. So now you have a whole cycle coming around and proof of the OCT, how it works. So basically, AMD is a disease. Like any disease, it has a background, an inception, an establishment, and a conclusion. So we're just going to talk about some of these things. There are essentially, AMD has two pathways. There is a pathway of atrophy, and there is a pathway of vascularization, which also leads to atrophy. So that's what we are afraid of in this disease. A drusen is a living thing. A drusen is something that is created, it grows, it reaches a threshold, and it regresses. So the point of the matter is that when you see a drusen, by the nature of its size and volume, you know that it's increasing, it hits a threshold, and it goes into atrophy. That's the larger the drusen, the faster the regression, and the more the disease process. So these are some examples you can see over a period of, this is a 9-year follow-up where you see the drusenoid material changing over time, regressing, flattening, and reaching the end result of AMD, which is atrophy. This is nearly a 9-year follow-up over where you can see. So there are some features which is most important in the OCT. How OCT explains the disease is that it tells you about key features that tell you when the disease is going to happen. So slides got a bit jumbled up. Even a drusen can be categorized into many types. They're called concave, convex, dome shape. You can call them homogeneous, heterogeneous. About the reflector, I'll just show you. You call it a convex drusen if it's dome shaped, a concave drusen if it's sharp. This is a drusen which is homogeneous inside. This is a drusen which is heterogeneous inside. This is called a core. So you have different features, and a drusen this is the most common type, a convex drusen which is homogeneous. This is a safe type of drusen. But a drusen which is pointed, a drusen which has got heterogeneous material inside, what I showed you, if it has a core inside, they are prone to disease. This is a drusen. These are on a single picture, you see different types of drusen. Something which is homogeneity inside, and it's hyporeflective to the RP, hyporeflective to the RP. A drusen which has got a variegate appearance inside. Each and every feature of these has a prognostic feature in which it tells you the disease is going to atrophy. Just skip some of these. And again, this is a beautiful example of a drusen which was homogeneous and it's now getting evolved. The homogeneity is being lost and it's becoming heterogeneous, and you know it's going to go to atrophy soon. Another one where you can actually see a core inside the drusen. So even in drusen, this is the most interesting thing that's come out. It's called ODSS, or drusen substructures, by which they've divided drusen into many types, and this is how it is. CHSL. The conical drusens have the most chance of going to atrophic effects, and the low core drusens are the least type. So even now looking at drusen, you know you can predict to some extent whether a patient is going to atrophy or not. And these are the signs of atrophy in a drusen. Quite interesting. Hyperreflective dots. This is how the disease is explained. Whenever you see a dot on top of a drusen, it's a flag of atrophy happening. It's quite interesting. What are these? These are actually thought to be retinal pigment epithelial cells that are got detached from the surface of the RP, and they're migrating anteriorly or upwards. So this is one sign. The more you have these, the more chance of this patient going into atrophy. You have a hyperreflective dots on top of the lesion, like so. And like so, eventually you see that they atrophy, and this is a really good biomarker of atrophy in AMD. So there is another thing called a pseudo-vitelliform appearance, where the material goes sideways. So the types of hyperreflected dots, there's an anterior type and a posterior. The anterior type is found in AMD. It's an atrophic event. So this is the thing. The pseudo, it looks like a vitelliform degeneration, but this is actually drusenoid material which is being pumped in above the RP. And this is also a sign of impending atrophy. You can see in this patient there are atrophic changes happening underneath the area of the vitelliform degeneration. Again, a marker. A new term, nascent GA. Nascent GA or geographic atrophy is the first stage of diagnosing geographic atrophy. Again, it's a sign. These are the signs. What you get is that you see a dimple. The layer of the outer plexigone just goes down. You see areas in which there is loss of the outer retinal bands, and you see these lines which are called vertical transmission lines. So whenever you see these in a large area or a small area, you know that that's an area in which the RP atrophy is going to happen fast. And the same thing you see, this is called subsidence. The layer just dips down. The outer nuclear layer dips down. So, and that corresponds to all these areas. This is what I was talking about. This is called a vertical transmission defect. You can see it in a variety of situations, and again, it's a marker to tell you that atrophy is happening. Again, you see a PED, but on top of the PED, you see vertical transmission defect, which all this means is that the layers, the RP on top of the PED is starting to atrophy. This is what we call reticular pseudodrusen. Again, I'm not just going to the details, but reticular pseudodrusen is like AMD on drugs or AMD on steroids. Everything happens faster. It goes faster to atrophy, faster to CNVM. I'm just going to skip this because it's a very cool thing. Okay. New concept of geographic atrophy is what happens, outer retinal tubulations, and what happens when do you see a case of geographic atrophy and you see that the atrophy is progressing or not. The next story is outer retinal tubulations. What happens in a patient, these are called outer retinal tubulations. You have circular structures. Like you can remember in your retinoblastoma, whenever the retina is at threat, the structures kind of rotate around each other. The ELM rotates around each other to capture some photoreceptors inside in an attempt to protect them. That's what's happening here. The whole retina, the outer retinal bands kind of rotate and kind of protect the photoreceptors inside, and you get these structures. And if you notice, they're over an area of atrophic retina or a scar. So that's the importance of this particular sign. It tells you that it's a degenerating retina, it's a progressing retina. Sometimes you stop treatment with anti-VEGF when you see these signs. So another, you have a scar and you've got all these beautiful outer retinal tubulations on top of it. And this is how the outer retinal tubulation, it looks. I mean, it's like things are scrolling on itself. This is how it looks on an NFAS or a coronal image. So we went down this path of the image. Okay, now there's another path, the destructive path of the vascular path. You've got drusen, vascular alterations, establishment, regression, and sequelae. So this is something that is really new. It's called recapitulation. Not all CNVMs are bad. That's a new concept. There is something called nascent or quiescent CNVM or non-exudative CNVM, where the CNVM doesn't grow, but it actually supplies the RP for some time before breaking into a CNVM lesion. It's called nascent GA or a vascularized quiescent CNVM. So it's actually a beneficial CNVM for some time. That's our current thinking. I might change it later, but this is what it looks like. You have a lesion over there, and when you do a beautiful imaging on OCTA or OCT angiography, you see a small vascular network over there. And that is the importance of all these diagnostic tests nowadays. It explains, this is like a precursor of a main CNVM. You can pick it up in an early stage. There's no fluid, but you see bumps in the retina, and these bumps are actually harboring a vascular lesion over there. This is another example. You see a bump, there's no fluid, but you see a vascular lesion over there on the OCT angiography. That's it, blown up. It's not yet dangerous, but it's there. According to statistics, about 28% convert to CNVMs within 2 years. So that's a high percentage. That's another one. Okay. Advanced AMD. You've got type 1, type 2, and this has been explained. Anything underneath the RP is called a type 1 CNVM. You see lesions over here. When you take the cut here, you see a lesion underneath CNVM, but you see activity on top over here. This is a type 1 CNVM. These are beautiful examples where the CNVM has broken through the brooks and has become a type 2 CNVM. The minute it does that, you see intraretinal changes. You see cystoid macular edema, you see hard X-ray. So it's something quite interesting to see. Changes underneath, you don't have much in the retina is not destroyed. When it breaks through, breaches the RP, you've got a lot of destructive retinal changes, as you see here. Again, disease process explained by OCT. We all started looking beneath this to this area after OCT came, and the whole new spectrum of diseases called the pachychoroid spectrum, or the dilated choroid spectrum of disease. Here you can see a lesion, but what you see more is something harboring underneath it, a dilated choroidal vasculature. Again, lesion, dilated choroidal vasculature. Study of the choroid is the most important, one of the most important things we have nowadays. So besides that, the types of PEDs. This is a fibrovascular PED. You see a PED with a lot of material inside. Again, you know that this is a source of the exudation and all those things. PEDs like this, which are tall, this is called a thumb-shaped PED, looks like a thumb. This is typical of a disease called PCV. You have vertically oriented, a triangular. Here you have an ICG proof that there's a polyp very close to it. Multi-layering is a brand new sign. You see different layers inside the PED. This happens, different layers you see here, this happens when a person has received a huge amount of anti-VEGF therapy, and inside the PED, fibrosis is kind of trying to contain the disease, but what it does is that it propagates the disease also. It makes a patient less resistant to further anti-VEGF. So again, the disease, a new disease process that is an intra-PED or intra-lesional layering is happening in this particular part, only discovered by OCT in about 3 or 4 years ago. These are beautiful images of the membranes within the PED. You can see all these membranes happening within the PED. RAP is a lesion where the PED breaks through the top. You can see it beautifully. There's a PED, and then there's a vascular tissue, but it's broken through. And this is demonstrated by the OCT wonderfully. No other modality could prove this as beautiful as the OCT does. You can see
Dr.
PED.
Oni, if you can just
I'm done, yeah. So I think this is good enough. So what I'm trying to say, I just like to show you the last 3 slides because I think that kind of summarizes the whole thing. I'm just going to go through I call this a metaphysical analysis. It's not of the disease. This is very key. You have a disease which starts with a drusen. It's an accumulative disease. It goes underneath the RP. And then you have changes in the drusen which happen as they grow, like aging, puberty, growth, old age, whatever happens. And then there reaches a time when, like you lose hair, they lose RP cells. They migrate upwards. That's a high reflective dots. And then they start to atrophy. And then they start to flatten. And then you get different things like nascent GA and GA. Eventually, at one point of time, the RP breaches. The RP is said to be the best anti-angiogenic factor, an intact RP. The minute the RP breaches, you have vasculature growing underneath it. And this vasculature proceeds to a type 1, which is under the RP, or it breaks through the RP and goes to a type 2 RP. Eventually, what happens is that you have a propagation of this vascular material. It outgrows its vasculature, and it starts to regress. When it regresses, you have either, if it's underneath the RP, you have an overlying atrophy of the RP. If it's breached the RP and the vasculature is on top of the RP, you have a scar. And both the end result of all these processes is what I said in the first sentence, atrophy. So AMD is a disease progressing to atrophy, either with fiber optic replacement or pure replacement and loss of tissue. So that is how OCT explains AMD. Thank you. Sorry, that's our conference. Please, and
can you just put it? Can you put it on, please? You just want to. Yeah.
So we have some eminent speakers for the conference, June 5-6, a whole national faculty list of 50 retinal imagers, and Dr. Shobha from Moorfields, Dr. Jay Chablani from Pittsburgh, Dr. Quirkus, who's done all the research on the things I've been talking about, non-exudative CNVMs. It's an amazing panel, and I'd like to invite you all to it's at Trivandrum. Thank you.
Thank you. Wonderful. Any questions?